We'll start with in follow-up, since we have been talking follow-up and redos. One of the questions that Dr. Dasmit asked me was, do we do calibration of the urethra after we've done the repair? And do we do uroflowmetry later on to objectively assess whether this stream is good or not? So Dr. Dasmit, would you like to?
I have been asking this question to quite a few people, and obviously, just like hypospadias, how would you repair it? There's a variety of answers that I've been getting. Personally, I have not been doing a routine uroflowmetry unless there is a complication, and Rama Jayanti was following also the same protocol. But what I have been doing is that after about a year or two, I ask the patients to do a home uroflowmetry. So I give them a syringe. I say you ask the child to pass urine into a mug and measure the number of seconds that he takes and measure the amount of volume that he has passed, and you do that for about a week, and you come and show me those, just tabulate it and come and show it to me, and then you average out the uroflowmetry, and I would say in most of the cases, if the result shows about 8 to 9 ml per second are being passed, I think that's an adequately good flow.
Good. You would like to add?
And routine calibration, I have not been doing it.
In the follow-up of hypospadias, one of the things which we have used is ask the child to pass in front of you if the child is more than 3-4 years, and then check for the abdominal straining, the stream. Or else if it's a younger child, then we ask the patients to send a video clipping on email, and that has worked pretty well. I do calibrate only if there is any doubt of stricture or any doubt of distal stenosis. Otherwise, routinely we do not calibrate.
There was in one of the presentations, there was a very strong statement made that it doesn't matter what suture you use, or it doesn't matter whether you stitch through or you stitch subcuticular, etc. I'd just like to ask the question, and the audience can participate. In our country, and these questions are all designed for what we have in our practice in this country, we have the non-availability of all these materials uniformly in various places, and each one has to work with what they have. So does it really matter, and should we be standardizing these things? Would you like to comment?
Personally, I have used only Vicryl for all the buried sutures and chromic catgut for all the skin sutures in my earlier years. Subsequently, because the Vicryl, being a braided suture, always tends to catch the surrounding tissues. So when you are pulling the Vicryl through, sometimes it catches some surrounding tissue, and that does look like it's causing some trauma. So then I switched over to PDS, which is quite freely available in India, and that seems to be working well. I don't think it makes any difference as far as results are concerned.
So it's more convenience,
more of a convenience,
and feeling comfortable with the suture.
Yeah.
Sanjay, would you?
I think our practice essentially, again, I think I agree with what Dr. Snodgrass said. You have a few things and you do them the same way every time. Our practice has essentially been to use Maxon for the inner layers and Vicryl as you come up, and catgut for the skin around the glands. It's probably a slightly more expensive option, but it's something that we have been doing and we are happy with, and we don't at this point of time see the need to change from that. It's something that works well in our hands.
So whilst on this point of the operation and taking care of post-op immediately, brings me to dressings, and dressings range from expensive dressings to very simple innovations. And again, this is a cost issue in our country and a convenience issue. So I'd like to ask again the panel, and maybe Dr. Mani can comment. Does it matter? Do you need a dressing at all? And if you put a dressing, then what has it got to be? I was brought up in the UK when we were operating. We had a special foam dressing which looked very elegant, but it turned out to be very expensive. We use a simple Tagaderm sandwich, and that seems to work well enough for us. So would you all like to comment first, and then we can probably ask Dr. Mani to also add to it. Go ahead.
So initially in the training we were using Dynaplast dressing, which was sought to provide some compression and avoid some kind of bleeding. But essentially if you're remaining in the planes, then you don't need the dressing to avoid bleeding. Bleeding should not be there at the finishing of surgery. Essentially we are also using the same Tagaderm switch dressing, but a lot of time in small babies, 6-7 months, it just comes off in day 1 or day 2, and it doesn't matter. Really, and I was talking to Rama today where he said he lets the catheter drip into the first diaper itself, and most of the time the dressing gets wet and it comes out the night of surgery itself, and he hasn't seen any difference in the results himself also.
Sivaji, would you like to? And even Dr. Snodgrass, if you would like to comment on these two issues, because I mean, I'm sure we'll have time tomorrow when operating, but
especially the patients who have the redo surgeries, when come with a failed some repair, the first thing that the parents they tell you, doctor, it is because the catheter came out accidentally just on the third or fourth day. So usually they tend to blame to the catheter which came on the third or fourth day, and this happens purely because the catheter is not secured properly. And since we practice in India, we know what are the problems that we face, or the patient that comes from the different class. Sometimes patients come from extremely poor family, and they may not be able to take a proper care of the wound. So what I do, even at JJ also, we used to do the same thing. We used to give a complete closed dressing, that as you see, the way I do it. And the catheter attached to the urine bag, again is closed, the junction within the dynaplast. And I leave this patient dressing like this at least for 10 days. I never felt there is necessary to change this dressing at least for 10 days. Very rarely, the child, when he strains to pass stool, occasionally he will pass urine around the catheter and then need to change the dressing. Otherwise, with this dressing, I am able to send this patient home, whatever the class of patient, even if he is staying in a very poor surrounding. And I am not worried because he is unlikely to pull the catheter, unlikely that it will hurt that main wound. So that is what I am comfortable with the dynaplast, complete closed seal dressing.
so I think dressings matter from where we come from. Yeah, go ahead.
No, even the catheter is a bit of a concern. So I use a simple infant feeding tube as a catheter. Now that is pretty stiff. So you don't want too much movement happening. So if you have a silastic catheter, the penis can lie around, it can be pushed into a diaper, it can keep moving, it doesn't make a difference. But with a stiff catheter inside, I don't think that's a good option. So the option of completely securing the dressing and removing only when you have to, which is like maybe 10, 12 days later or 7 days later. And in fact, I go a step further, even if the patient has passed urine into the dressing, which is because of some bladder spasms or pericatheter, I just let that dressing be in position as long as it's not stinking too badly. That's the only time when I tell the patient, you come back and then we'll remove it. Many times the parents are not confident enough to manage the dressing or the catheter at home. So in that case, then we tell them you can keep lying in the hospital, and we send them home only after the catheter removal.
Go ahead.
Only one comment about Dr. Mane's dressing. We have all seen it. We were conducting a pediatric urology workshop 5 years back, and Dr. Siripati remarked, this dressing, even an atom bomb cannot dislodge. So that's a very secure dressing.
Sanjay, this question's to you. You know, you keep seeing patients on the ward, and you surely interact with the parents. You know, what do you feel about quick discharge versus in-hospital stay? Because again, in our country, some institutions can afford it, and some institutions can't afford it. For instance, the corporate sector versus, say, a government sector or a semi-private sector.
Yeah, at least, you know, from interacting with parents, I think a lot of it depends upon how comfortable the parents are with looking after this child. You might have a patient who's coming from a very, very rural background where the parents are pretty confident about looking after a child, and they are able to look after the child very well even at home. And you might have a really uppity family where both the people are in the IT sector doing very well, but they are so nervous about their child that any little twist and turn, they tend to panic, and these people tend to remain in hospital for longer. So I mean, it is unusual to see that the better off patients who have better facilities at home tend to linger in hospital longer, as against those who are more confident and are able to look after their children at home, even if they are coming from a relatively modest background.
What is the trend in the West? Is it stay in the hospital or go home as soon as possible?
This question comes up a lot, you know, when I travel, and so you have to discern kind of a couple of aspects of it. And just to answer very briefly, clearly the evidence from the United States is that we send our patients home the day of surgery for almost every hypospadias repair that we do, and you see our results. So if we're talking from an evidence basis, there is no evidence that mother's care at home makes a difference to the outcome of the patient. So then you have to turn it around and say, well, what about this comfort factor and all of that? And a large part of that is driven by the surgeon more than it is the family. Do not believe that we don't have parents whose first answer is, I don't think I can take my child home after this operation. We send them home. So a lot of, again, I'm not saying that your culture is directly related to our culture. I'm not saying that. But I'm saying purely from the standpoint of the urethroplasty outcomes from the repair, what is it that you're doing in the hospital that's protecting them from what's going to happen at home? We have poor people too. They may not be quite the level of poorness you have, but they're poor for our society, but we don't show any data that says that the outcomes in them is worse than the outcome in other people.
So there's only one difference. One is the filth that many of the people live in. So the standard of hygiene is not as good as the worst people in the United States. That's one. Second thing is that you don't get calls after you have sent the patient home.
Well, I'm sorry to say that yes, I do. I take my calls. I don't have a trainee take those calls, so I know about those calls.
We can be really hounded by those calls.
Yes, we can be.
And the one way to prevent those calls is just keep the patient with you.
Well, that way the trainee and the nurse deal with it instead of you. Yeah, okay, fair enough. Well, but I'm going to say, you raise it, and this question has come up earlier today too, about what other factors besides what we talked about might impact outcome. So maybe hygiene, maybe just poor nutrition and related to poor health. Well, again, you guys have a fabulous opportunity here. Categorize your patients according to their status and report that. Does it, in fact, make a difference? It's easy to tell yourself, I better keep this patient because their house is dirty, but they live in a dirty house all the time. Maybe it doesn't make any difference for their outcome.
Go ahead, Sanjay.
No, the choice of sending patients home earlier, was it when it started a medical decision, or was that a sort of insurance-based decision?
It was an insurance-based decision, but we started that in 1983 or 84. When I started my training in 1982, all those patients stayed in the house like yours do the whole time the catheter was in. We had lots of patients in the hospital, and every morning we made rounds and unwrapped the child from the catheter, right? And then we started sending them all home. And so I don't know of almost an exception in the United States where kids are operated on for hypospadias, regardless of their background, regardless of how far away they live from the hospital, regardless of any factor that you can come up with, they have day surgery and they go home. And yet our results show that they have good outcomes. There is no correlation to duration of hospitalization with outcome. But if you think there is, do us a study and show us what's different. I mean, that would actually be helpful, but just to sit around in a panel and say, well, our patients are poor, our patients are dirtier and all that, I'm not picking on you, but I'm saying this is what we've done. The theme of this program is evidence-based. So there's an easy, low-lying fruit study to do. Compare the higher income patients that work in the IT sector to those patients that are living on the street and tell us if there's a difference in their outcomes.
So I agree that there is no difference in the outcome. I would concede that, because many of the patients we do send home provided they agree to go home.
I think the point being made, and I think these questions were put up because these are common questions and these are problems that face us every day in deciding on what to do with our patients. And I think the very reason for putting these up is to just open up investigating avenues. I think we need to look at our data, look at our experiences, share our experiences and say, I send them home, you keep them in hospital. What do you feel? What do I feel? And that's how we are going to learn. So I'm just putting the questions up just to stimulate the thoughts. I know what to do. Regarding technological aids, I'm sure all our hypospadiologists in this audience who like to do hypospadial do use magnification and good lighting. Now, my residents complain that, sir, it costs 20,000 or 25,000 rupees to get even into 2x in a loop. And can you get it from the hospital? So what are the practical aspects of getting all our young colleagues to move towards having a headlight and having so I would like the panel as well as say Dr. Sripati, Dr. Mane, and please don't tell me I don't need it, it'll defeat my argument. So let's see let's see how we can find a way to make this possible. Yeah.
So undoubtedly, loops are extremely important, I think.
Okay.
It makes life easy. You're doing a much better job. I don't think anybody can dispute that. There are people who say that I don't need loops, but that's okay, that's up to them. But I think it's being unfair to the child if you're not using loops.
To the surgery, yes.
Yeah, and there are quite a few inexpensive loops available, Chinese made, etc. So if you can't afford the good ones, you can start with those.
Sripati, would you like?
I just have a quick question to you, Ashley. Where is this 20,000 rupees loop available? because I think
12,000.
no. It's at least
12,000.
a good
If
one.
you want,
we are not talking about the back
See,
the back street maneuvering. that happens
You
in Pune.
drive a BMW car.
No.
There are a whole lot of people who drive a little Maruti.
I think
you
it's,
know.
I think a good quality loops is at least 40,000.
Yes,
You
yes.
go to Carl Zeiss, it's about
Yes.
almost about 80 or 90.
You're right.
If you go for designs for vision, it's almost that.
About almost a lakh. And I'm talking about the low-end entry-level loop that you can just put on. And at least I'll tell you what the loop does. My residence puts the loop on and looks over it.
Well,
Yeah.
I have an answer for the residents who can't afford a 40,000 loop. And it's a very simple, I still use that. We'd all agree that magnification is a must, no deny. But when I was with Duckett in 1992, he used to use a visor, a lens which comes down over your spectacles, and it gives 2 times, 4 times magnification. And whenever you don't want it, all you do is just flip it off, and you're perfectly fine.
Yeah.
A company called Basco makes it, I think, in Bangalore, and it's 8,000 rupees. So that's for all of you.
Yes, Dr. Sivaj.
I think the loop is a one-time investment. Even the resident today, what they get as a salarium, or rather the stipend is adequate enough. They can easily afford to buy the one loop. And we don't have to change it every year or every 5 years or 10 years. If it's a good quality loop which lasts for a longer time. And I think best way to practice is we can practice for even simple cases like even herniatomia or orthopexy, all neonatal surgeries, pyeloplasties, intestinal atrasias. The way you can practice, get used to that. And obviously for hypospadias, doing hypospadias without loop is I will put it like is a criminal.
I don't think you need to change the loop. You need to change something behind it, I think, very often. One more question that we would take. I think the question on the timing was well answered in the presentations. I mean, there's no difference between doing it early and doing it late. And as we know from our practice, babies in the urban areas coming now at the appropriate time, they go into the net, they know it has to be done between 6 months and 18 months, and they've got one more window around 3 years before they go to school, so they time it well and they come. And that's the practice that we have in the urban hospitals. And I'm sure in the very many other hospitals, they come at various ages. For the first time, we've done the first time repair at 14 and 15 years of age. So these things happen. So I think if you know that it doesn't really matter and we follow the techniques and we do it correctly, you can get as good results both in the young ones as well as in the old ones.
Just on the timing, one interesting point which I noticed in Warren's presentation was that some children have been operated as early as 3 months. So what criteria have you been using? Because traditionally, why 6 months were decided was that by 4 or 5 months you get an LH surge. So you wait for that to develop the penis slightly more, and then you operate at 6 months. So what is the compelling reason for doing it at 3 months?
Well, in fact, most of that penile growth that occurs from after birth is already done by 3 months. And so in full-term healthy babies, we will do them as early as 3 months. The vast majority of those are distal repairs, and the glans is already bigger than 15 millimeters or so, and the anesthetic risk is no different at that age than it is in an older age, at least as far as we can determine at this time. So in our country, we don't have waiting lists. And so if I see a patient in the office today who has, for example, a distal hypospadias, full-term healthy baby, I can schedule them for surgery at that age. There's no need to make them wait. So I'm not advocating doing it, but we do it because our system allows us to.
I think what I'm doing here is just keeping it going because the coffee has not yet come. Let me go to one very important part of discussion which might not come up during the workshop. And this is again, Dr. Mane, Dr. Raj, Dr. Venkat and the panel, please participate. Parental questions of what will happen 20 years from now. I get asked repeatedly, will he be able to do it? Will he get babies? Will he have a happy married life? Then they bring the other son and they say, he's got twice the length of this guy. What's going to happen? And I think these are serious questions. I know that size matters, but these are an important matter here, for these young parents, first child, and they're having this problem. And I don't have an answer. I just say from the evidence that we have, it looks like that they will be happily married and they will bear children. That's all I can say, and that's what they hope that I will say. But can somebody throw light on these issues? Yeah. I don't know. I didn't give Rama a chance, and I think he ran away. But anyway, the panel. Would you like to start?
I think it's a lot to do with the psychological aspect, and you have to explain to the relative. That's what I do. That no two penises are alike. They need not be the same size. That 2 inches of an erect penis is adequate for penetration and for procreation. And as far as handling the child's psychology is concerned, I think that requires tremendous amount of input. And that part we generally ignore. But I think that's very, very important.
A lot of studies have shown that infertility is not the issue, but sometimes in a hypospadias which has not been fully repaired, there is a stricture or it's a very baggy urethra, then the ejaculation may be a problem. So these some of these adult patients do need assisted means of reproduction. I recall one patient came to me. We do significant number of adult hypospadias now at Hypospadias Foundation. Adult hypospadias patient came about 3-4 months back because he had a distal meatus which was not at the tip, and the rest of the urethra was also very baggy. And he was seeking a repair in the hope that he will have a child. But essentially what he was having was azoospermia, which needed a different kind of management. So giving a hope to that kind of patient in terms of hypospadias repair was not adequate, and this was no way related to hypospadias itself. So I think infertility itself is a different, and it can be a mechanical or the problem with the sperm production itself versus the mechanical issues posed by a hypospadias itself.
Thank you. Sanjay, you'd like to comment on it?
Again, I think I will agree with what Dr. Snodgrass said. We don't have information. Information, at least from our group, is being collected, so we probably have something down the line. But these are questions that are asked, and at least from what is available in the literature, I think people have quoted. It is interesting to see about measurements. I think the measurements with the calipers, like what was being done, I saw the similar thing being done in the NU hospitals yesterday. So I think that is something that can be easily done and followed up.
Venkat, you want to comment?
No, nothing. I just wanted to take issue with you on the third question. Will you have a happy married life? Speak for yourself.
Okay. Sir.
To tell you, some of my patients have already married, and they are because we have been doing hypospadias from 1975 onwards, and some of them are 30, 35 years, and they have got children. I have seen many of them have grown up, resulting in a lot of problems. Some of these patients who have got a small penis, the size of penis is small in them because it is a 5-alpha reductase deficiency. At the time of puberty, expect them to grow to near normal size. And then when you do hypospadias surgery, when they reach about 16 or 18 years of age, some of them do have a little small penis and also have an erectile dysfunction. Recently, I had a patient whom I have operated 30 years ago in Tirupur town. That fellow got married, but he couldn't consummate the marriage. Then the other party went inside the house and then ransacked everything, and the fellow came running to me, asking me to give a certificate saying that he can have a normal sexual activity. I said it needs some documentation, and therefore as such certification is not possible from my end. I mean, that has to be sorted out by us, how we can give a certificate for a fellow can do normal sexual activity. Now, similarly, what happens in some of these proximal hypospadias, they do have a little enlarged prostatic diverticulum. This prostatic diverticulum is sometimes a remnant of prostatic utricle into which the ejaculatory ducts open inside. Many of them come with recurrent attacks of epididymoarchitis, and it's a really a trying problem for them. Several years they go through the epididymoarchitis, and then we have no answers to them, and many of them are sterile as a result of that. And some of these fellows in whom there is a rudimentary prostatic utricle, when they have a scan outside at the age of 25 or 30, some fellows say, you've got a rudimentary uterus. These fellows get really annoyed, and one of the boys ran to me and said, am I a female? I said, no, you are a male individual. And this fellow started crying. After 5 days later, he went to Ooty and then came back and said, I am a male individual. I asked him, how do you know? He stayed there for 5 days, had a call girl, and had a jolly good time for 5 days, and came back and said, I am perfectly all right. I mean, these fellows go through a lot of emotional problems, and as a pediatric surgeon, our job is over by 16 or 17 years of age. Then if you live long enough like me, and then in the same place, they do come quite often.
So on that note, I think we'll call it today. Thank you so much. Thank you everyone for your comments, and thank the panelists for their participation. Thank you.